Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Now imagine, just for a brief second, that this was your patient. What is one of the first physical exam findings that you recognize? Would it be his blue eyes? Would it be his hair? Or would it be his skin that appears somewhat yellow? We're going to be discussing this and much more on this presentation on liver pathology. This is covered in your book, Medical School Pathology and Step 1 Review. You can scan the QR code to get to the updated material on the website. Now, jaundice, right? We know that term. Jaundice, the yellow discoloration of the skin due to liver injury. The first indication of jaundice is usually scleroicterus, right? Which is characterized by a yellow discoloration of the sclera. Speaking of sclera, if the sclera were, let's say, blue in a child, what should be on the differential? Osteogenesis imperfecta, right? Expect them to have bone issues, right? But anyway, we're talking about jaundice. So patients with jaundice, it usually presents with yellow discoloration of the sclera initially. Jaundice is caused by high blood bilirubin levels, which usually exceeds 5 milligrams per deciliter and rise in response to bilirubin metabolism disruptions. The first indication of jaundice is scleroicterus, which is characterized by the yellow discoloration of the sclera. Never forget that, because it will show up like this. But this is not an initial presentation. This is actual full-on becoming discolored, looking yellow, right? Jaundice is the yellow discoloration of the skin due to liver injury. Now, in order to understand jaundice, it is helpful to understand bile production, storage, and secretion, right? So let me take you back to biochem, right, of the liver. Bilirubin is produced when the red blood cells are consumed by those macrophages of the reticuloendothelial system. Then heme, protoporphyrin, is transformed to unconjugated bilirubin, right? UCB, unconjugated bilirubin. And this unconjugated bilirubin is transported to the liver via albumin. You remember albumin, the major transport protein? Bilirubin is converted into bile by the hepatic enzyme uridine glucuronoltransferase, or UGT. And bile is transmitted into the bile canaliculi and then stored in the gallbladder. Following a meal, the gallbladder releases bile into the duodenum via the ampulla of Vater in order to aid the digestion of lipids and cholesterols. And when intestinal bacteria convert bile to urobilinogen, it causes the brown feces. And bile is also partially filtered by the kidney and reabsorbed into the circulation, turning urine yellow, right? Now let's get into some pathology. Viral hepatitis is an inflammation of the liver parenchyma due to a viral infection. Causes of viral hepatitis include the hepatitis viruses, as well as Epstein-Barr virus and cytomegalovirus, okay? Acute hepatitis is caused by hepatitis virus and can proceed to chronic hepatitis. Symptoms of viral hepatitis include jaundice, fever, malaise, nausea, and an increased liver enzymes, specifically the ratio to know is an ALT greater than AST. Hepatocyte apoptosis is a sign of inflammation, which affects the lobules of the liver and the portal tracts. With high liver enzymes, some of the cases could be asymptomatic. When symptoms show, they last usually less than 6 months in acute hepatitis. Symptoms of chronic hepatitis persist for more than 6 months. Inflammation mostly affects the portal tract and carries a risk of developing into cirrhosis, right? You know what cirrhosis is, with those fibrotic nodules. Speaking of which, we know that viral hepatitis can not only cause inflammation, but it can also lead to the progression of malignancies, right? As we see here, right? If you take a look, we have various imaging from radiologists as well as pathology micrographs. Now, what this is showing in the imaging is MRI with a right lobe mass with a high intensity lesion, okay? And the microscopic images are showing cholangiocarcinoma and hepatocellular carcinoma involving the liver. So just keep in mind that viral hepatitis can lead to the generation of cancer in the liver. Here we have the histopathology from a liver biopsy from a patient that shows inflammation and abundant brown pigment granules. Specifically around the portal tracts, you can see a lymphocytic infiltration. And this patient actually has Dubin-Johnson syndrome, right? Now, you've heard of Dubin-Johnson syndrome, right? What should be on the differential when you hear that word? Maybe rotors. And you can tell them apart because the prevalence of the biopsy or the tissue specimen will be brown or black in Dubin-Johnson, but there will be no discoloration with rotors. Both of them are inherited autosomally recessively, though. Now let's talk about cirrhosis. You're going to see this a lot. Cirrhosis is the last stage of liver damage, and it's marked by bands of fibrosis and hepatocyte regenerating nodules that disrupt the normal hepatic parenchyma. Now, if you look closely to the right here, look really closely, you'll see a bunch of micro nodules, right? With diffuse areas of pallor. Here, let's take a microscopic look. Here we can see on the imaging of this histologic section various bands highlighted by the reticulin stain, right? And that is staining some of the liver fibrosis. And in between that, you see nodular areas. This is cirrhosis in the setting of alcohol liver disease. Now, under the endothelial cells that line the sinusoids, stellate cells that are present in fibrosis are responsible for the cirrhosis. Now, there are many features that you will need to be aware of associated with cirrhosis, which include jaundice, right? We know what that looks like. Physical exam findings such as splenomegaly or hypersplenism. Portosystemic shunts, right? You should be able to pick up on that. Gynecomastia, spider angiomas, portal hypertension, ascites, altered mental status, hepatorenal syndrome, right? Impaired detoxification due to the liver being under a pathological state. Asterixis, right? You remember that physical exam finding, classic for cirrhosis. Palmar erythemia, caused by the hyperestrogenism. Hypoalbuminemia, right? Edema, and coagulopathy, caused by the impaired synthesis of clotting factors. See, the liver is going to affect multiple different systems, right? So there's ways to pick up on this. Now, the degree of deficiency of the liver is followed by the prothrombin time, or the PT. And here we have a close-up of a micrograph showing cirrhosis. And you're going to need to know this, right? You should be able to recognize this because you will highly likely see this. And what stain is being utilized? The trichome stain, right? With that bright blue of the fibers of fibrosis. And here we have a close-up of a patient with alcoholic cirrhosis. Note the Mallory high line. Now, can you point that out? I'll give you a clue. There's 3 eosinophilic pink globules near the top. You should be able to spot them. That's Mallory high line. And here we have CT imaging from a patient with liver cirrhosis. If you look closely, you can see the nodularity actually on the liver. And here, microscopically, you can see nodularity in a patient with cirrhosis, specifically steatohepatitis. Note the thick bands of fibrosis. And even here, if you look closely, you can see vague little beigeish circles, which goes along with the cirrhosis. And here we have a cartoon of a patient with cirrhosis. Note the difference between the healthy liver and the cirrhotic liver. Patients may present with severe pain in the abdomen. And here we have cirrhosis showcased by a caudate lobe hypertrophy on ultrasound due to cirrhosis. Now, what stain's being utilized here? Trichome, right? And trichome staining those areas of fibrotic tissue blue, while the nodules have this nodular circular appearance, right? And note more cirrhotic stains, right? Or imaging, I should say, at the microscopic level. Cirrhosis is a big deal, as you can tell by this monochromatic and material decomposition images of cirrhosis utilizing radiology. Now let's talk about alcohol-related liver disease, okay? Alcohol consumption is the most common reason for liver disease in the West. If you take a look to the right here, you can see microscopy of the liver showing evidence of alcoholic hepatitis. Note all those white circular areas? That's the fatty change. And if you look closely, you can also see cell necrosis and pink hyaline globules of the Mallory Weiss bodies, or the Mallory bodies. Now, alcohol consumption can cause damage to the hepatic parenchyma, which leads to alcohol-related liver disease, as outlined here to the right with this depiction of what happens with chronic ethanol intake and how the liver is affected at the hepatocyte level. This is the pathogenesis of alcohol-induced liver injury, right? Drinking too much alcohol, acetaldehyde affects the NADH production, right? You get a fatty liver. Oxidative stress causes the hepatocyte injury. You get lipid peroxidation, more injury. That promotes the fibrosis of the liver in and of itself due to the hepatic stellate cell activation, right? Now, the buildup of fat in hepatocytes causes the liver to become heavy and greasy. Alcohol consumption can cause chemical damage to the hepatocytes, i.e. alcoholic hepatitis. The metabolites of alcohol, called acetaldehyde, induces the liver damage. Hepatocyte swelling and the development of Mallory bodies are its defining features, right? So don't be shocked if you're asked to identify a mammary body. Cirrhosis is a consequence of long-term chronic alcohol-induced liver damage, and it typically affects 10 to 20% of people who drink excessively, right? Throwing shots back and whatnot. Non-alcoholic fatty liver disease, NAFLD, right? NAFLD. It's characterized by fatty changes, hepatitis, and/or cirrhosis that occur without the use of alcohol, right? Now, without the use of alcohol, yes, without the use of alcohol. Hence, non-alcoholic fatty liver disease. This frequently presents in the setting of an obese patient. Non-alcoholic fatty liver disease is a diagnosis of exclusion. In non-alcoholic fatty liver disease, the ALT is typically greater than AST, especially for examination purposes. In non-alcoholic fatty liver disease, you might notice some ballooning degeneration. In non-alcoholic fatty liver disease, you might note some inflammation and even fibrosis occurring. Here's a cartoon that shows a depiction of the etiology of non-alcoholic fatty liver disease that's affected with inflammation. Note the progression to fibrosis or cirrhosis or even with cancer. And here we have histology from a patient with non-alcoholic fatty liver disease. Note the micrograph shows a lobular necroinflammation and interface hepatitis. And here we have 4 representative micrographs showing non-alcoholic fatty liver disease, it being stained with O staining, which stains the adipose cells, the fat basically, as well as a non-alcoholic fatty liver and D, quantitative succinylation analysis, right? Now let's talk about something you are definitely going to be asked about, hemochromatosis. Excess bodily iron causes hemosiderosis, which can cause organ damage and tissue deposition in the conditions known as hemochromatosis. Free radical production causes tissue damage, which is mediated by an autosomal recessive deficiency in iron absorption in primary hemochromatosis, or chronic transfusions, which will be secondary hemochromatosis. The HFE gene, often due to mutation in C282Y, is the cause of primary hemochromatosis, which you will need to know. C282Y causes tyrosine to take the place of cysteine, amino acid 282. Hemochromatosis usually affects adults, and clinical features of hemochromatosis include cirrhosis, secondary diabetes mellitus, bronze skin, cardiac arrhythmias, gonadal dysfunction, and testicular atrophy. Hemochromatosis is often referred to as bronze diabetes. Lab findings in hemochromatosis include increased ferritin, increased serum iron, right, makes sense, and increased percent transferrin saturation, right? There's so much iron going around that transferrin is saturated. Body stops producing transferrin because it doesn't need it anymore, and hence the transferrin itself is decreased. Regarding hemochromatosis, liver histology shows that the hepatocytes have accumulated brown pigment. Now you might be looking at this image and saying, Dr. Wheeler, I don't see any brown here. And I would agree with you. I see a bunch of blue, but that's because this has the iron stain, right? With hemochromatosis, you can stain the iron if you're a pathologist, and you can see the iron appear as blue, right? Would you say there's a lot of iron in this specimen? I would. 4+. And even dermatologists can pick up on the presentation, finding the effects of excessive iron. For example, we have histopathology of a skin lesion here that's showing primary hemochromatosis presenting with the patient in porphyria cutanea tarda. But more importantly, especially for testing purposes, remember that the brown pigment present in biopsies of patients with hemochromatosis is lipofuscin, which is a byproduct of the turnover and wear and tear of peroxidized lipids. And remember that the Prussian blue stain differentiates iron from lipofuscin. You'll likely be asked that. They like to trick you sometimes. But you won't be tricked because you know that Prussian blue stains iron and the lipofuscin just naturally is there and looks brown on H&E. Now there is an elevated risk of hepatocellular carcinoma in the setting of hemochromatosis. So remember that as well. Hemochromatosis is treated by phlebotomy. Now let's move on to another commonly tested condition, Wilson disease. Wilson disease is due to an ATP7B gene abnormality, which you must know, that affects ATP-mediated hepatocyte copper transport on an autosomal recessive basis. Wilson disease is characterized by copper not being transported into bile or incorporated into ceruloplasmin. In Wilson disease, copper accumulates in the hepatocytes, leaks into the serum, and then accumulates in tissues. Tissue damage results from the hydroxyl free radical generation that is mediated by copper. Wilson disease first appears as behavioral changes, dementia, chorea, and Parkinsonians. And classically, we have the Kayser-Fleischer rings on the cornea. Copper buildup in the basal ganglia are examples of neurologic manifestations of Wilson disease. Laboratory results in Wilson disease show increased urinary copper, serum ceruloplasmin, and copper on liver biopsy. The sole treatment for Wilson disease is D-penicillamine, which chelates copper. Wilson disease is associated with increased risk for hepatocellular carcinoma. What is this? You must know. Kayser-Fleischer ring associated with copper deposition in Descemet's membrane of the cornea. You will see this, and you'll know it's a Kayser-Fleischer ring associated with Wilson's disease, right? You got this. I believe in you. Wilson's disease has an autosomal recessive pattern of inheritance, right? It's autosomal recessive, and we can see that to the right here in this cartoon. In regards to Wilson's disease, the normal absorption and distribution of copper is affected, right? So take note of this cartoon here if you like. It's highly unlikely that you'll be asked about this, though, because on clinical vignette, there'll be a lot of physical exam findings and labs that will point you in the right direction. Remember, though, the ATP7B is the deficiency that you must be aware of. And in Wilson's disease, remember that the basal ganglia are affected. And here we have real life MRI brain imaging from a panda showing the typical signs of Wilson's disease. Just kidding, it's not from a panda. That's to help you remember that if you hear giant panda sign, think Wilson's disease. Now let's talk a bit about primary biliary cirrhosis. Primary biliary cirrhosis is the destruction of intrahepatic bile ducts by autoimmune processes. As we can see here on this micrograph of primary biliary cirrhosis, note the bile duct intraepithelial lymphocytes. Primary biliary cirrhosis is associated with granulomatous disease. Primary biliary cirrhosis occurs more often in women above the age of 40. Although the etiology of primary biliary cirrhosis is unknown, anti-mitochondrial antibodies are frequently present. And we can see that on this imaging here with the immunofluorescence staining pattern of SP100 antibodies, those nuclear dots, as well as anti-mitochondrial antibodies. And here we have a needle core biopsy from a patient with primary biliary cirrhosis. Note the inflammatory infiltrate. In regards to primary biliary cirrhosis, there could be a chronic non-suppurative destruction, cholangitis, damaged bile ducts, and infiltration of mixed chronic inflammatory cells surrounding the bile ducts. At some stages, the bile ducts can even disappear due to the inflammation. Now, primary sclerosing cholangitis is inflammation and fibrosis of intrahepatic and extrahepatic bile ducts. Here we have a CT scan and the finding of a patient with primary sclerosing cholangitis. Note the dilated common bile duct and the intrahepatic biliary radicals with calcified hepatolithiasis. Primary sclerosing cholangitis has a periductal fibrosis with a onion skin appearance. On contrast imaging, uninvolved areas expand, giving them a beaded look. Primary sclerosing cholangitis has an unknown etiology, but is related to ulcerative colitis. With primary sclerosing cholangitis, P-ANCA is positive, right? So P-ANCA is positive in primary sclerosing cholangitis. And speaking of ANCA, where will you see a positive C-ANCA? Wegener's granulomatosis, also known as granulomatosis with polyangiitis, right? Remember that? What are some symptoms of Wegener's granulomatosis? Runny nose, nosebleed, congestion, shortness of breath, right? Hoarseness, right? But anyway, primary sclerosing cholangitis is associated with obstructive jaundice, cirrhosis, and cholangiocarcinoma. And here we can see a micrograph of a liver biopsy from a patient that shows onion skinning. Onion skinning? Yes, onion skinning. So we should know that this is primary sclerosing cholangitis. And keep in mind that primary sclerosing cholangitis can show up on various types of imaging, such as a cholangiogram, as we can see here to the right. Now let's talk about a very, very, very important condition known as Reye syndrome. Reye syndrome occurs in children with viral illnesses that take aspirin. Reye syndrome is characterized by fulminant liver failure, encephalopathy, hypoglycemia, and increased liver enzymes. Reye syndrome can result in coma and even death. To the right, we can see histopathology from a patient with Reye syndrome. This is from an autopsy. We don't want to see a child at an autopsy over something like this, okay? Let's talk about another condition, hepatic adenoma. Hepatic adenoma is a benign tumor of the hepatocytes. To the right here, we can see a micrograph of a hepatic adenoma demonstrating a regular reticulin scaffold. And here we have the H&E from that same hepatic adenoma. It's just not stained with reticulin. Note the nodular area and the somewhat prefibrotic area. Now, hepatic adenoma development is correlated to the usage of oral contraceptives and can actually go away when the medication is stopped. So be on the lookout for a young woman in the clinical vignette who's on oral contraceptive with some sort of liver issues, right? Now, particularly during pregnancy, there is a danger of rupture and intraperitoneal hemorrhage in patients with hepatic adenomas. These subcapsular tumors actually spread when exposed to estrogen. Here we have a micrograph of a hepatic adenoma. Note the inflammatory hepatocellular adenoma that is present here. And keep in mind that reticulin stains the somewhat prefibrotic reticular fibers surrounding the nodules of the hepatic adenoma. And again, on H&E, this is what it would look like, a well-circumscribed nodule. Now this is bad. This is hepatocellular carcinoma. Hepatocellular carcinoma is a malignant tumor of the hepatocytes, right? This is not an adenoma. This is a carcinoma. To the right here, we can see grossly what hepatocellular carcinoma looks like. Risk factors for hepatocellular carcinoma include chronic hepatitis, right? HBV or HCV typically, cirrhosis, non-alcoholic fatty liver disease, hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency, right? Those patients, right? You remember them with that emphysematous presentation, right? Budd-Chiari syndrome, Aspergillus infection due to aflatoxin production, and even a liver infarction, right? A lot of risk factors. Hepatocellular carcinoma typically presents with severe hepatomegaly and ascites. The prognosis of hepatocellular carcinoma is poor. To the right here, we can see a specific type of hepatocellular carcinoma, which you probably won't need to know. At your level, just remember hepatocellular carcinoma. But just for giggles, for the future pathologists out there who diagnose this is a fibrolamellar hepatocellular carcinoma. Now, hepatocellular carcinoma produces the serum tumor marker AFP, which stands for alpha fetoprotein, right? You'll be asked this. You need to be able to recognize it. Here's an image of a well-differentiated meaning it looks like normal tissue, kind of. This is a well-differentiated hepatocellular carcinoma. And here is an FNA clot section from a patient with hepatocellular carcinoma. And here are a couple FNAs from a hepatocellular carcinoma. At your level, you won't need to be able to recognize this, but I put it here just to torture you, right? Now here is more hepatocellular carcinoma. This is more FNA, right? Note all the vascular structures, right? As you remember, tumors like to promote angiogenesis, right? To get the blood and nutrients and oxygen to those rapidly growing cancerous areas, right? Now I'm going to torture you some more with some things that you don't need to know, like FNAs, right? Yep. More FNAs. This is a clot section from an FNA. More FNAs, right? Okay, enough FNAs. More FNAs. Okay, torture. Now, liver metastasis. You're going to have to know this too. You might see something like this. Keep in mind that compared to primary liver tumors, liver metastasis is more common. Remember that, because you'll probably be asked that. So don't say I didn't warn you that if there's a cancer in the liver, it's more likely to come from somewhere else than to have been grown in the liver itself, okay? For example, to the right here, we see a needle core biopsy from a liver specimen showing a micrograph with some sort of metastatic cancer in it. It looks a bit epithelioid to me. The clinical diagnosis of liver metastasis may reveal a nodular free edge of the liver and hepatomegaly. The most usual sources for liver metastasis are colon carcinomas, pancreatic carcinomas, lung cancers, and breast cancer, right? Those are the type of cancers that are most likely to metastasize to the liver. Radiology of liver metastasis usually show numerous nodules in the liver. And you completed another very important presentation. I'm so proud of you. You have no idea. Fantastic. If you have any questions, comments, concerns, let me know. I'm here to support you. I want to see you win, right? And until next time, I'll see you later.